all, while I'm sharing my screen, I would like to thank Dr. Asim, Dr. Akhtar, and all of the LCs for providing me all the support throughout this 1 or 2 weeks, which I am in. So thank you so much, all of you. You all are wonderful. So just like what I felt like while starting working, that we should have some working documents and working policies, because like I work most of the time in emergency, and then for the uniformity of how do we work and what language we will speak, it is very important if we have some written document which we all follow. It always provides us as a guideline, and we can always refer it to. So the topic which I chose is the lactational mastitis and its diagnosis and management. It's kind of a lengthy topic. I will forward it into the policy or guideline group. You can read it too. What does it entitle? It has an introduction, that how do you define it? Then a little bit of its epidemiology, how common it is, and then etiology, like what are the possible causes. Most common, we all know, partial, let me make it a little bit bigger. Yeah, blocked milk duct, oversupply, infrequent feeding, nipple excoriation, rapid weaning, maternal stress, and sometimes maternal malnutrition. Then some of the organism, Staph aureus is the most common, and then MRSA we should always think of. How does it manifest? And the diagnosis. In the diagnosis, I would say it's a clinical diagnosis, so no investigation are required usually. But if the mastitis is not responding with the antibiotic, then ultrasound is the best first step. And then I listened to a lot of discussion about the cultures of the milk. And then there are some instances where blood culture is also indicated. I would suggest if we reach to that point, then it should be out of our domain. We should refer them to their family doctors to get it done. We should not take that onus. If there is a failure to respond to antibiotic, or if we need that there's an escalation of care is required. Because it needs a lot of coordination, I don't feel like we are the best person to deal with that. Then I have included some of the differentials here, and with some picture and with some kind of a differentiating point, that how could we differentiate mastitis from severe engorgement, from best abscess, and then the blocked ducts, I think, yeah, plugged duct. And then sometimes galactosele. Galactosele is a benign cyst, which is caused by the milk retention. And then one of the scariest thing is IVC. That can be one of the differential. In the treatment, it's mostly pain management, cold compressor. And then the specific management is the antibiotic. Definitely the Caflex and cloxacillin is the first line. Then if it is not responding, then clindamycin. And also I have written down some cautious here, that what cautious. So the words to mention, if there are 2 failed antibiotic, then I would suggest that we should refer them again to their family doctor for a more organized care. For example, any specialist required, any breast milk cultures, any blood culture required. Prevention is mentioned that sometimes probiotics like the lactobacillus, but I do not myself have a lot of experience in that. I just looked into the literature, and literature has suggested that probiotics sometimes help, especially if taken in the late pregnancy. Recurrence is very much uncommon. So this is a very important point, that recurrence is not common. But if there's a recurrences that are happening, or they are not responding to oral antibiotic, then there's something more happening that will require more thorough investigation and maybe a specialist referral. So here again, knowing your limitation comes in. This is what I put in, and I'm happy for the feedback from the group before finalizing. And I kept it like we should keep, whenever we make a policy, every 2 years need to be revised, because the medicines changes so much, and I feel like this is a reasonable period that we should review the policies every 2 years, whatever we finalized on. So thank you so much for listening, and I'm open to any feedback from the group.
What would be the suggested mechanism of notifying the family physician that the
Yeah.
team wants to agree on? Because this would be an issue of timeliness, correct?
Yeah, yes. So I feel like either we can ask them. I'm not sure about it. We have to think about that flow process. But we can tell them that we are starting you on a second course of antibiotic. Meanwhile, you should contact your family doctor to tell them that this was a primary issue and I'm on a second course of antibiotic. And my lactation consultant has advised me that I should contact you. If that doesn't work, then I need to be seen by you. So, or if we can, there is a mechanism where we always record their family physician, like in our initial visit, who is their family doctor. So if we have that information, if we have started the second course of antibiotic, we can write down a letter. This XYZ patient was seen, she had a mastitis, we have completed one course of antibiotic, we are starting second course. So if she did not respond, then she will contact you for further care. Something like that should be in place so we all know what to do rather than getting into some kind of a awkward situation that now we have to organize so much of the care for that patient, which I think is totally not in our domain to organize those cares, because we are not going to follow up the culture result. We are not going to treat the resistance cases one off in the 100 cases. So this is what I felt is the safest mechanism, but I'm open for the suggestion and from the advices from the group.
I think that's wise. We don't have a complete CPP on the mothers. We don't have, you know, an effective history. And that although this is an acute issue, I think it would be good for us to certainly have a written mechanism for updating the primary care provider. I wonder at whether or not there's any need for telephone call, because as far as I know, we only send a letter for the first initial visit, and any follow-up visits that we have with the families, we don't necessarily have an automatic send of a letter. So that might be part of the workflow to sort out.
Yeah, or if we can just inform them that we will provide care which is not a specialized care. If you need a specialized care, then it need to be through your family care provider, like family physician, not through us. Because that is not our scope. Like somewhere, if there's a kind of a privacy policy where we tell them what are being covered in our visit and what are not being covered in our visit. So then if you require any specialized care, then this is not the proper like the avenue to look for that need to be through your family physician, and then explicitly having that expectation communicated to the mom rather than just trying to treat or trying to help. Because we as a physician, we as a healthcare provider, we always try to help, but then knowing your limitation, where to stand up is also very important.